Immunodeficiency disorders. A state in which the ability of the immune system to fight infectious diseases is compromised or entirely absent. A person who has an immunodeficiency is said to be immunocompromised. A boy with congenital ID lived in a bubble for 12 years before he died. Immunodeficiency is considered to be present when infections are frequent and severe, caused by opportunistic microbes resistant to antimicrobial therapy. Classification of ID: primary congenital ID in the sense immunodeficiency. Okay. Primary congenital, secondary acquired. Primary genetic mutation, monogenic single gene, polygenic multiple genes, malnutrition. No, wait a minute. Secondary is acquired one. Is due to malnutrition. Sometimes viral and bacterial infections can be a cause. For example, AIDS. Immunosuppressive therapy like corticosteroids, excessive protein loss, burns, nephrotic syndrome, like that. Then primary or acquired can affect natural immunity and acquired immunity. Natural immunity in the sense phagocytic cells, complement proteins, and acquired immunity in the sense T cells and B cells. Distribution of primary immunodeficiencies: combined B and T cell about 20%, phagocytic about 18%, complement about 2%, cellular T cell 10%, humoral B cell 50%. Pattern of infections and symptoms associated with primary immunodeficiencies: antibody cell mediated immunity, complement, phagocytosis, regulatory T cells. T cell defects: DiGeorge syndrome, congenital thymic aplasia, a congenital defect that is marked by absence or underdevelopment of the thymus gland, hypoplasia, hypoparathyroidism, facial abnormalities, cardiovascular abnormalities may be there. Features of DiGeorge syndrome: children may present with tetany. And then in the complete form, extreme susceptibility to viral, protozoal and fungal infections, profound depression of T cell numbers, absence of T cell responses. Management of DiGeorge syndrome: fetal thymus tissue graft till 14 years old, and B cell 14 weeks old. Yeah, B cell defects: gamma globulinemias. Patients with B cell defects are subject to recurrent bacterial infections but display normal immunity to most viral and fungal infections. Diverse spectrum ranging from complete absence of B cells, complete absence of plasma cells, low or absent immunoglobulins, selective absence of certain immunoglobulins, genetic transmission, autosomal recessive, X-linked disease. Females are carriers in the sense they are normal, but they are carriers. Males manifest the disease. Gamma globulinemias. X-linked A gamma globulinemia, XLA, or Bruton's hypogammaglobulinemia, congenital disease, the most common type 80 to 90%. Defect in Bruton's tyrosine kinase, BTK. The defect involves a block in maturation of pre-B cell to mature B cell in bone marrow. Features of XLA: reduced B cell counts to 0.1%, normally 5 to 15%, absence of immunoglobulins. Then affected children suffer from recurrent pyogenic bacterial infections. Selective immunoglobulin deficiency, congenital disease, IgA deficiency. Most are asymptomatic but may have increased incidence of respiratory tract infections. Some have recurrent RTI and gastrointestinal tract symptoms. X-linked hyper IgM syndrome, congenital disease characterized by low IgG, IgA and IgE, and variable IgM levels, most frequently high. Management of immunoglobulin deficiencies: periodic intravenous immunoglobulin reduces infectious complications. Severe combined immunodeficiency, skin congenital disease, causes of skin enzyme deficiencies: ADA, adenosine deaminase deficiency, PNP, purine pyrophosphate phosphorylase deficiency, toxic metabolites accumulate in T and B cells. Features of SCID: increased susceptibility to viral, fungal, bacterial, protozoal infections starting at 3 months of age. Management of SCID: infusion of purified enzymes, gene therapy. Leukocyte defects: quantitative and qualitative. Quantitative means congenital granulocytosis. Defects in the gene including GCSF, granulocyte colony stimulating factor, features pneumonia, otitis media, abscesses. Then qualitative defects: congenital diseases. Defect in chemotaxis, LAD, leukocyte adhesion deficiency, defect in the adhesion molecules responsible for leukocyte trafficking and migration to sites of infection. Then defect in intracellular killing. Defect in intracellular killing, chronic granulomatous disease. Defect in intracellular killing, chronic granulomatous disease. Defect in the oxidative complex responsible for producing superoxide radicals. Congenital disease, CGD. Neutrophils lack the respiratory boost from phagocytosis, characterized by recurrent life-threatening bacterial and fungal infections and granuloma formation. Complement deficiency. Deficiency of all complement components have been described, C1 to C9. Laboratory diagnosis of ID. Complete blood count, total and differential evaluation of antibody levels and response to antigens. T and B cells counts. Flow cytometry will be performing. Measurement of complement proteins and function. CH50. Assessment of phagocytosis and respiratory boost. Oxygen radicals. Conclusion: immunodeficiency may be congenital or acquired. It can involve any component of the immune system such as cells, antibodies, complement, etc. Most common presentation of immunodeficiency is in recurrent infections that may be fatal due to delay in diagnosis and lack of appropriate therapy.